intubated on 50% oxygen. Saturation is 90 and a systolic blood pressure of 130 with a heart. And he has had about 750 mils of IV saline. And recommendation is to take a 12V DCG, and blood gas has been done. So what sort of blood gas would you expect in this lady? Any idea? Chanika or Chanika? Chaturika, what would you expect to see in this blood gas if you have done a blood gas in this lady? In this gentleman, not lady, sorry.
Metabolic acidosis.
Okay, what else? So can you give some values for blood gas, for an imaginary blood gas that you would expect to see in this gentleman? Like start from pH and put some values, then we can see whether your one is tallying with the one given here.
pH around 7.2.
Okay.
Then partial pressure of carbon dioxide. Around 5 kilopascal.
Or in millimeters mercury?
40.
Okay.
Partial pressure of oxygen. Less than 10 kilopascal.
Okay, that means less than 75 millimeters mercury.
Yes.
Okay. Bicarb.
Bicarbonate. 8 to 20 millimole per liter.
20.
18 to 20.
18 to 20. Okay, fine. Base excess.
Base excess minus 2.5.
Okay. What would you expect in this lady, in this gentleman to have? What's the metabolic or respiratory derangement that you would expect him to have? What's the blood acid-base disturbance that you would expect in this patient to have? So this is a elderly gentleman who had a cardiac arrest and he has been resuscitated with a CPR for about 5 minutes, and currently he's on 50% oxygen, saturation is 90 and blood pressure 130 and tachycardic. So what sort of acid-base disturbance would you expect this man to have?
Metabolic acidosis.
Okay, metabolic acidosis. What else? Any other thing? So there's okay, you get the metabolic acidosis because of poor tissue perfusion. Because of that, you can get a lactic acidosis, isn't it?
Yes.
Lactate would be high, and with resuscitation, using lactate as an endpoint, lactate as a guidance, you can give fluids and try to normalize it. And in the meantime, after the arrest, there might be a period where the patient is not getting properly oxygenated and ventilated, isn't it? So you can expect to have poor oxygenation and ventilation as both, isn't it? Poor oxygenation will be reflected by the low PaO2, and poor ventilation will be reflected by what? High carbon dioxide, isn't it?
Yes.
Okay, so that's how when you see a patient without doing a blood gas, you can in most of the occasions you can work out what will be the acid base rearrangement. Okay, now let's see what's the blood gas here. Okay, I'll ask somebody else. Dilini, can you interpret this blood gas, please? Baina to kian Dilini.
pH is 7.1.
Okay.
Therefore, it's acidosis.
Okay.
Oxygen, partial pressure of oxygen is 7.5. It's less than the normal values.
Okay.
Therefore, poor oxygenation is there. And
So this,
there's...
Hold on. So this guy is on 50% oxygen. Can you remember? Ventilated with 50% oxygen. And
yes.
he has a PO2 of 56. So what could be the rough expected partial pressure of oxygen in blood?
40% into 7.5. It's around 300 millimeters of mercury.
Okay, but he's having 56, isn't it? So oxygenation is very poor, isn't it?
Yes.
So you can expect poor oxygenation after cardiac arrest because of there's will be a brief period where the patient won't be getting anything because of the arrest. Then somebody will try to mask the patient. Sorry, somebody will try to oxygenate and ventilate the patient using a bag and mask, and then maybe LMA then intubation. So there'll be there'll be a gap where the patient's oxygenation will be poor, isn't it? So you can expect it. Okay, the other parameters, CO2 bicarbonate base excess.
Carbon dioxide partial pressure is 7.6.
Okay.
It's in higher level.
Okay. So this could the carbon dioxide could also be contributing to the acidosis, isn't it?
Yes.
Okay. Then
and bicarb level is less than 22 and it's 16.
Okay.
It's more towards the metabolic acidosis.
Base excess is minus 10, isn't it? So normally it's plus 2 to minus 2. So it's also well above the normal range, isn't it?
Yes. Plus 10 have to add it to become to the normal range.
Okay. So what's your final diagnosis?
It's acute metabolic acidosis, uncompensated.
Okay, you can clearly say that there's a respiratory component as well. So diagnosis is this guy has a acute metabolic and respiratory acidosis. You can tell like that as well. So when you say that there's a respiratory acidosis, it says that the metabolic acidosis is not compensated, isn't it?
Yes.
Okay.
Okay, sir.
So, okay, I'll ask somebody else. Somebody has asked to zoom the screen. I can't run this as a slideshow because when I press the slideshow button, the PowerPoint crashes. I'll try to fix it next time. I couldn't get it fixed. Sorry about it. And somebody else has asked the difference between oxygenation and ventilation. Harshani, what's the difference between oxygenation and ventilation? Can you tell? Or anybody, any volunteer who can tell the difference between oxygenation and ventilation? Hashan Indika, do you know? Hashan, do you know the difference between oxygenation and ventilation? Okay, Huawei Y7 Pro, do you know? iPhone guest, Isurupalli Guru. Can somebody tell? So one person has, so I have been telling oxygenation and ventilation. I have been using these words interchangeably, but Nobody asked the meaning. One person has asked what's the difference between oxygenation and ventilation. Jeevanta guest. Kavya, Kanchana, Kavya, anybody?
Ventilation means when oxygen supplies to lungs, up to lungs, and oxygenation up to tissue level.
Can you repeat? Tell again, please.
Ventilation means up to the lung, and oxygenation from lungs to tissue level.
Okay, so oxygenation is the process where oxygen gets extracted, like oxygen gets the process by which the oxygen gets from the atmosphere to the pulmonary capillaries. So in order to get the oxygen, the respiratory mechanism should be working, and once the oxygen is in the alveoli, it should diffuse across the pulmonary capillary barrier, isn't it? So in order for oxygenation to happen well, the respiratory muscle should be working, and there shouldn't be any problem between the alveolus and the capillary. And in addition, there should be a blood supply. There should be a continuous blood supply from the heart to the pulmonary vasculature. So for oxygenation to occur, the respiratory mechanism should be working well, and there's this pulmonary capillary alveolar capillary barrier that should be also intact, and then the heart should be able to pump blood to the pulmonary vasculature. So any of these process, if there's any disturbance in or problem in any of these processes, there will be impairment in oxygenation. For example, if the patient is not say if the respiratory rate is like a 6 or 8, there won't be adequate minute ventilation to the lungs. Minute ventilation is tidal volume into respiratory rate. If the patient is breathing at a lower rate, he won't be getting enough oxygen. And regarding the barrier between the alveolus and the pulmonary capillaries, there can be anything. For example, if the barrier is thickened in diseases like such as pulmonary fibrosis, so there will be impairment of oxygen. That's why patients with pulmonary fibrosis or fibrosing alveolitis are cyanosed. Then if you have something in the alveolus, something filling the alveolus, such as fluid in pulmonary edema, or an exudate, such as in pneumonia, there will be a problem in the diffusion barrier because oxygen won't be reaching the alveoli to diffuse into the capillaries. And the other thing is, if there is no proper blood supply to the pulmonary capillaries, say in low cardiac output states, if the patient is in shock, the right heart won't be pumping adequate blood to the pulmonary circulation for oxygenation to occur. Even if you get enough oxygen in the alveolus, if you don't get an adequate blood supply to the lungs, there will be poor oxygenation. And in the extreme situations, if there's a shunt, say there's a patient with a ASD who has a reversal of the shunt, so the blood will be traveling from the right atrium to the left atrium. So the majority of blood will be bypassing the lungs. So in that case also there will be poor oxygenation. So ultimately oxygenation is the pulmonary end capillaries getting oxygenated blood. The hemoglobin in the pulmonary end capillaries being oxygenated, combining oxygen. That's the process of oxygenation.
Yes, sir.
Anybody having question regarding that? So basically, we tell that there will be a problem in oxygenation. One thing is if that is mainly called the oxygen cascade. Then you consider oxygen being delivered from the atmosphere up to the level of the cell. So one thing is oxygen will be if the going from the atmosphere into the alveolus. So for that to occur, concentration of oxygen in the atmosphere. If you go like high altitude, the meter 5000 the partial pressure of oxygen will be low, isn't it? Atmospheric pressure aduwe. So then you would be inspiring a low partial pressure of oxygen. Then if the respiratory mechanism is not working well, if the patient, then there will be low partial pressure of oxygen at the alveolar level. Then if there's a problem with diffusion, like in fibrosing alveolitis, or if the alveolus is filled with something like edema fluid or exudate or anything, or even blood, if there's pulmonary hemorrhage, there will be problem with diffusion. Then in the extreme situation, you get a shunt where you won't get enough blood to the pulmonary circulation because the blood will be bypassing the pulmonary circulation. The example I gave is a ASD. It can have an ASD as well. Or then the other thing is, other situation is called a VQ mismatch. V is ventilation, Q is perfusion. If there's an imbalance between ventilation and perfusion, you get poor oxygenation. For example, say a patient is breathing well, but there's a problem in the heart and he is not generating adequate cardiac output. Say, for example, in cardiogenic shock, then the patient will get a VQ mismatch. So the main three mechanisms which are involved in poor oxygenation are either a diffusion problem, either a VQ mismatch, or a shunt. Shunt is the extreme situation of a VQ mismatch where you get the ventilation, but you don't get the oxygenation. Sorry, the perfusion. Okay, I'll explain Lahir, don't worry. Okay, so then the ventilation is the process by which ventilation is the process by which the respiratory muscles help us to do the gas clearance. For example, if you take carbon dioxide clearance mainly depends on the ventilation, mainly on the respiratory muscle mechanics. So if the respiratory mechanism is not functioning, you will get a problem with ventilation, in turn clearance of carbon dioxide. So in order for oxygenation to happen, sometimes oxygenation can happen without an intact respiratory muscle mechanism. For example, in an anesthetized patient, after giving the induction agent, propofol or anything, and after giving the muscle relaxant, if you hold a tight fitting oxygen mask to the face of the patient, there will be bulk flow of oxygen towards the alveolus. Like if there's a partial pressure, if there's a pressure difference between the face mask and the alveolus, if there's a flow difference, there will be flow occurring. And without the respiratory muscles working, there will be oxygenation of the patient. But in that patient, because the respiratory muscles are not working, carbon dioxide will be accumulated because he won't be able to clear the carbon dioxide unless the respiratory mechanism is working. Okay. Did you understand the difference between oxygenation and ventilation?
Yes, sir.
So ventilation is the process by which mainly carbon dioxide gets cleared, but it's needed for oxygenation as well. If there's a ventilatory problem, we are more concerned about carbon dioxide clearance. If there's a problem in diffusion, or if there's a VQ mismatch where there's imbalance between perfusion and ventilation, or if there's a shunt which bypasses the lungs, there will be a problem in oxygenation. Okay. So that's the question answer for the question, what is the difference between oxygenation and ventilation? Then another Lahir has asked, so can you explain why you have told here respiratory and metabolic acidosis both? So Lahiru, if you look at the blood gas, the first step is how is the patient. So I have given a brief explanation. This patient has a cardiac arrest. So there will be a period where oxygenation and ventilation will be impaired. So we can expect respiratory and metabolic acidosis, isn't it? So just imagine the patient who was arrested in the ward. So after the arrest, the patient will not be breathing and there will be no circulation. So because he has stopped breathing, there will be poor oxygenation and there will be poor clearance of carbon dioxide since the respiratory muscles are not working. Then there will be a period where somebody is trying to hold a bag and mask and tries to ventilate the patient. But sometimes the patient might not be ventilated properly, depending on the skills of the person who is attempting ventilation. Then if you put an LMA, we can't, sometimes if the LMA is displaced or if the LMA doesn't fit to the patient, there will be problem with oxygenation and ventilation. So there will be in a cardiac arrest patient, you can't expect him to have a normal oxygenation and a normal CO2 immediately after cardiac arrest. You must expect some derangement. And even regarding the metabolic component, there'll be a period where the heart stops. If the heart stops, there will be a circulation going on, isn't it? So there will be poor oxidation of the tissues, which in turn will lead to metabolic anaerobic acidosis. Sorry, anaerobic metabolism, which is called lactic acidosis. Okay. So then there's another question. Sir, can we say there's type 2 respiratory failure? Yes, we can say type 2 respiratory failure is if there's a problem in both oxygenation and ventilation. Like there be high CO2 and low oxygen. Then there's another question. Sir, does hypothermia or hypothermia affect ABG? Yes, it will, but at your level, don't worry much about it. So when you interpret blood gases, you have to consider the temperature as well, but at your level, don't worry much about it. Then there's another question. So can you explain oxygenation again? So oxygenation is the process by which the end capillary, pulmonary end capillary blood get oxygenated, which means that the hemoglobin in the pulmonary end capillary bed combines with oxygenation. So for oxygenation to occur, there is a whole path starting from the atmosphere up to the level of the pulmonary end capillary bed. Okay, so oxygenation, for the oxygenation to occur properly, you should have a optimum partial pressure of oxygen in the atmosphere. So that's why, as I explained earlier, if you go high altitude, because of the reduction in partial pressure of oxygen in the atmosphere, there will be reduction in partial pressure of oxygen. You get 21% oxygen in the 21% of the normal concentration of oxygen is 21%. No, so if you are at 180 m, which is at the sea level, so the oxygenation, the oxygen partial pressure would be 760, because 760 is the partial pressure of oxygen, partial pressure in the at the level of the sea level. So it will be 760 into 0.21. But if you go high altitude, it will be like something like 500. The partial pressure of oxygen will be 500 into 0.21. හරිනේ, sea level එකේ 760 121යි. හැබැයි උඩට යන්න partial pressure එක අඩු වෙනවනේ. ඒතර 500 121යි. So if there's any mechanism that reduces the inspired partial pressure of oxygen, it will lead to poor oxygenation. Then the other thing is, if there's problem in the respiratory mechanism, if the patient is not breathing, he won't be able to extract oxygen, so that will also lead to poor oxygenation. Then at the level of the pulmonary capillary bed, we have the alveolus, and surrounding the alveolus we have these pulmonary capillaries. So if there is any process disturbing the exchange of oxygen at the level of the alveolus and pulmonary capillary bed, there will be poor oxygenation. One thing is diffusion. If this barrier is thickened, then the oxygen won't be able to diffuse properly. Other thing is VQ mismatch or shunt. Shunt is you get oxygen to the alveolus, but the pulmonary capillaries don't get perfused because blood is being bypassed between the right side and the left side. So for example, I gave the VSD and ASD. So in ASD, if like 90% of the blood is being bypassed from the right side to the left side straight away through a hole in the interatrial gap, the lungs won't be getting enough blood. So there will be a problem in oxygenation of the blood. Okay. And the other thing is VQ mismatch. If there's a problem, if there's an imbalance between the ventilation and the perfusion, you get enough oxygen, but if you don't get enough blood to the pulmonary capillaries, there will be a problem, poor oxygenation. Okay. Then there's another question. Sir, can you explain the answer for this case scenario 2 again? Okay, I'll do it. So FiO2 minus 10 වලින් ලැබෙන්නේ percentage එකක්ද නැත්නම් කිලෝ පැස්කල්ද? FiO2 minus 10 වලින් හම්බෙන්නේ කිලෝ පැස්කල් ගාන. දැන් FiO2 එක 50 නම් මේ arterial එක expect කරන්නේ 50 හරියට 10. 40 කිලෝ පැස්කල්. So 40 kilo pascals into 7.5 is 300. හරිනේ? So can you explain the answer for this case scenario 2 again? So Lahiru, what's the problem now? Do you have any questions? Lahiru? Lahiru? Lahiru, is it clear now? I hope I have explained this. Do you have any problems with regard to this? Do you have any other problems regarding this case? Anything about ventilation, oxygenation, or any other question regarding this case? मैं type कर ले वाला तो केले में cutting है होना lazy ने. Oh no, it's okay. You can send a message. Any questions? Is it clear to everybody? හරිද?
Yes, sir.
Do you want to? Lahiru, is it clear? Lahiru නෑනේ. Lahiru. Okay. Third one. Okay, so you're called urgently to the ward to see a 71-year-old male patient admitted with an acute exacerbation of COPD who has had a respiratory arrest. The nurse gives you a SBA handover, following which you carry out a rapid ABCD assessment and find A is clear and there's a oropharyngeal airway in place. OP is oropharyngeal. B being ventilated with oxygen 15 liters per minute using a bag mask with reservoir. Saturation is 90. There's widespread V's in both lungs and coarse crackles at the left base. Circulation pulse is 56, sinus brady, BP is 150 or 94. Disability, there's no eye opening, incomprehensible sounds, flexes to pain with a GCS of 7. And E, nothing gross, IV in right forearm. And somebody has done a blood gas. So, okay. Danung, what would you expect? Can you create a blood gas for this? Can you create a hypothetical blood gas for this patient? We can go through the blood gas later.
Yes, sir.
Yeah.
I'm reading questions, sir.
All right, okay.
As patient is a COPD patient, present with exacerbation of COPD, there can be poor oxygenation as he is on 15 liters of oxygen and saturation is poor. I will expect oxygen, partial pressure of oxygen below 90.
So saturation is 90. If the saturation is 90, what sort of PO2 would you expect? How can you work it out? How can you work out the relationship between the saturation and partial pressure of oxygen? Say, if you are being given a saturation of any saturation, how can you work out the partial pressure of oxygen?
I have no idea, sir.
Oxygen hemoglobin dissociation curve you have the relationship between in the y-axis you get the saturation and in the x-axis you get the partial pressure of oxygen, isn't it?
Yes, sir.
Upper flat part because of that if the saturation is 100 it's difficult to predict partial pressure of oxygen unless you know the inspired partial pressure of oxygen, isn't it? Ne?
Yes, sir.
Saturation 100 නම් අපිට partial pressure එක එන්න පුළුවන් 90 ඉඳන් ඕන ගානක් 90 100 200 300 400 500 but if you know the inspired oxygen concentration then we can get a rough idea of the partial pressure of oxygen, isn't it? Ne?
Yes, sir.
Okay, so saturation is 90. What sort of partial pressure would you expect? Matlab curve එක?
It's below 90, sir.
Saturation 92 93 වලදී තමයි partial pressure 60 වෙන්නේ. අර curve එකේ you don't have a picture now. So if you take the relationship between the saturation and the partial pressure, you get the top upper part and there's sudden drop, isn't it?
Yes, sir.
So that point is roughly 60. Can you see this? Can you see this? Can you see the screen?
Yes, sir.
Yes, sir.
Follow this cursor. So make sigmoid part then you get the flat upper part. So when the flat upper parts come to a certain point, the saturation drops dramatically, isn't it? So this partial pressure at which the saturation drops dramatically is known as the ICU point. ICU point එක සාමාන්‍යයෙන් partial pressure එක මෙතන තියෙන 60යි x axis එකේ y axis එකේ මෙතන තියෙන සාමාන්‍යයෙන් 93 92ක් විතර 90.
Then
So in
should be 60.
Oh, it should be roughly around 60, isn't it? So we are worried about this point in the ICU. That's why we call the ICU because the partial pressure drops dramatically. Sorry, the saturation drops dramatically at the ICU point. So in the ICU, this is for your extra knowledge. Unless the patient has ischemic heart disease or traumatic brain injury, in the ICU point, we are satisfied if the patient has a partial pressure of oxygen of around 60. That saturation is around 90 to 93. Unless the patient is having ischemic heart disease or head injury, we are happy that if the patient is having saturation of 60. The other importance of this is you demarcate type 1 respiratory failure from this point. Type 1 respiratory failure කියන්නේ partial pressure of oxygen 60 අඩු නන්නේ නේ?
Yes, sir.
Okay, that's an extra bit. Okay, so you expect a P simple AO2 of 60 in this
60.
patient, right? Roughly 60. Then carbon dioxide.
As he is in respiratory arrest, there can be hypercapnia, sir.
Okay, so what would be pH? pH would that?
pH should be 7.25.
Okay, 7.25. PO2 is now 60 with 15 liters oxygen with sats of 90, and CO2 is how much?
CO2 like 55.
Okay, 55. Then bicarb.
Bicarb, it's 20 hours.
Why? So history says that the patient is having COPD. In a COPD patient, like say there's a COPD patient who is eating and drinking and walking. If you do a blood gas in a COPD patient who is otherwise okay, what sort of blood gas would you expect in that patient to have? Say when පොරක් ඉන්න අවුරුදු 70ක දවසට සිගරට් 20ක් බොනවා. එහෙම අවුරුදු 30 සිගරට් බීලා තියෙනවා. Comes to the ward, comes to your clinic. And you want to do a blood gas and see to check how his gas is. What would you expect? කතා ගන්න පොරක් ඉන්නවා. You do blood gas, but he's a heavy smoker. 20 pack years for 30 years.
Yes. There can be
normal COPD නිකන් හිතලා කියන්නේ imaginary blood gas එක. pH එක 7.25 do low and normal එකට 7.3233 වගේ දාන්න. නැත්නම් 31 වගේ.
yes.
Okay, oxygen එක
60.
okay,
Yeah.
60 or maybe 70, 80. It can range from 60 to 100, right?
Yes.
Okay, CO2
50 also.
okay, fine. Carbon dioxide, sorry, bicarb
20.
how much?
20.
Okay, I'll tell you. Okay, right, fine. So I asked, okay, fine. So I asked about the normal patient. Say there's a patient, a heavy smoker who comes to the medicine clinic, and you're interested in doing a blood gas. Is there anybody who wants to have a go? Any volunteer to give to put some values and to formulate an imaginary blood gas for this patient? How do you gamble? Venura?
Yes, sir. This is an elderly patient with unassessed comorbidities. He already has a background of COPD, so he should be in type 2 respiratory failure, and it is acutely values.
Oh, not for this patient. A COPD patient, 71 years old, who is smoking 20 cigarettes per day for 30 years, and you do a blood gas in him. So what just tell me some values for blood gas in COPD patient who is a heavy smoker.
Yes. His partial pressure of oxygen would be near normal or slightly reduced, and there would be a hypercarbia,
Okay.
and due to the hypercarbia, there could be some respiratory acidosis.
So tell
the
me some immediate
pH
values. pH how much?
pH around 7.1, 7.2, and hypercarbia around PaCO2 around 50, 55, and PaO2 around I can't remember the normal values.
Okay, fine. Bicarb
would be a little bit around 20, sir. 22, 20. Yes, sir.
Okay, fine. So in a COPD patient who is a heavy smoker, who is eating and drinking and who is otherwise fail, if you do a blood gas, as both of you are told, you might expect a slight rise in carbon dioxide. So because of that, the patient will have a respiration 1.32 or 7.33 or even 7.35 towards the lower side. Then if you look at the oxygen, it will be slightly low, isn't it? Maybe PO2 will range from 60 to 100. Sometimes 70 or 80 would be normal for a COPD patient. Then the catch in this case is the bicarb, because the patient is having a respiratory acidosis. In the long term, the kidneys will try to compensate for that. because of the rise in carbon dioxide, the kidneys will try to compensate by reabsorb by retaining more bicarbonate. So in a chronic COPD patient, you will have slight rise in bicarb. So all of you are told that the bicarb will be around 20. It's not correct. Usually in a chronic patient, bicarb of like more than the normal value, maybe 26, 27, 28, 29, 30, or even if it's a very long history, the bicarb will be at the range of even 35, 30, in the 30s, and base excess will be positive. Okay, the patient will be compensating to the respiratory acidosis by creating a metabolic alkalosis, because in a normal patient, because he's compensating. So that's what I wanted to. That's the point I wanted to teach by asking the values you might expect in a patient who comes to the clinic. So in chronic COPD, because of the compensation to the respiratory acidosis, because the kidneys are working well, he will have a high bicarb, which is known as metabolic alkalosis. හරිද ඒක? ඒක තේරුණාද? So when we when we evaluate this patient, we have to keep that in mind as well. Sometimes when we do the blood gas, so first thing is, as you all can see, there has been a problem with ventilation and oxygenation. If the patient has a respiratory arrest, there will be a period where the patient doesn't breathe. Respiratory arrest, the patient doesn't breathe. So there will be accumulation of CO2. So we can expect that there will be a high CO2. And in the data given, it says that with 50 liters, the patient is saturating 90. So that means the patient is not having good oxygenation. So then we can expect that the patient is having poor oxygenation. The PaO2 may be around 60. And if the CO2 is high, invariable, there should be acidosis. So the pH value should be less than 7.35. Let's assume that 7.31 and PaO2 is 60 and CO2 is maybe 60. Then coming to the bicarb, sometimes the patient can have a high bicarb because of the pre-existing metabolic alkalosis, because he has been compensating for a while. But on top of this insult, if say this patient had a cardiac arrest, because the heart is not pumping well, there will be a metabolic acidosis, so which can override the pre-existing metabolic alkalosis. If the patient has a cardiac arrest because of the poor tissue perfusion, then anaerobic metabolism, there can be a metabolic acidosis, which can override the existing metabolic alkalosis, and bicarb can even drop to maybe 15 or 10 if there's severe metabolic derangement. So in that case, the patient can have metabolic acidosis as well. But if there is no metabolic derangement, the patient can have a respiratory acidosis, poor oxygenation, and a metabolic alkalosis because of the pre-existing metabolic alkalosis. Are there any questions regarding that? How the patient can have a respiratory acidosis plus a metabolic alkalosis? The patient gets a metabolic alkalosis because of the pre-existing metabolic compensation, and provided that there is no derangement in the circulation. Make it in respiratory skill විතරයිනේ. But if the patient has a respiratory arrest, there will be impairment of oxygenation as well, isn't it? If the patient is not breathing, then there will be inadequate tissue perfusion, which will invariably lead to a metabolic acidosis. But if the metabolic acidosis is unable to override the metabolic alkalosis, the ultimate result will be metabolic alkalosis. In the metabolic part, bicarb will still be high or within normal range. Okay, let's look at the blood gas in this patient. So Harshini, can you interpret blood gas? So on 15 liters, there's a question. Case 3 did not understood. I'll explain again. Harshini,
Yes, sir.
can you interpret this blood gas? So now you know the history, right?
And his pH is 7.26, sir. Therefore, it is acidosis. And he's having a 85% oxygen concentration, and his partial pressure of oxygen is 19.5 kilopascal. So it is
It's low. It's very low, isn't it?
yes, sir.
Okay.
Therefore there is a poor oxygenation.
Okay.
And his partial pressure of carbon dioxide is less than the normal value.
Okay.
Therefore, there is a respiratory acidosis part, and his bicarbonate is more than 26. It is 36. So it may be due to a pre-existing metabolic alkalosis.
Okay.
And his base excess is plus 12. Therefore, 12 bases should be added to normalize the pH.
So what's the final diagnosis?
Therefore, this patient is having respiratory acidosis.
Okay. And what else?
And with pre-existing metabolic alkalosis.
Or you can say somebody has asked a question whether you can say either compensated respiratory acidosis or respiratory acidosis with metabolic alkalosis. Both answers are correct. So somebody has asked a question like that whether you can say either respiratory acidosis with compensation instead of saying respiratory acidosis with metabolic alkalosis. Both are correct. Better to say there is respiratory acidosis with compensation.
Okay, sir.
Okay. Okay, so somebody has told that case 3 is not understood and එතකොට COPD කෙනෙක්ට තියෙන්නේ metabolic alkalosis එකක්ද respiratory acidosis එකක් නෙවෙයිද දෙකම තියෙනවා COPD කෙනෙක් තේරෙනවද ඒක COPD කෙනෙක් ගත්තම there is retaining of carbon dioxide නේ හරිනේ so because retaining of carbon dioxide ඒ කියන්න දැන් respiratory acidosis එකක් තියෙනකොට ඒ compensate කරන්නේ metabolic alkalosis එකක් ඇවිල්ලා අපි ඇත්තටම until diagnosis say kiyanne the patient has a compensated respiratory acidosis කියලා but analyze කරලා බැලුවම ඇත්තටම තියෙන respiratory acidosis තමයි primary problem එක ඒක compensate කරන්න metabolic alkalosis එකක් තියෙනවා ඒක තමයි analyze කරාම තියෙන එක නමුත් අපි දැන් සාමාන්‍ය භාවිතයේදී කියන්නේ in day to day life we just say that the patient is having a compensated respiratory acidosis instead of saying that patient is having respiratory acidosis and metabolic alkalosis. Okay. Your name is not there. May at 4 at 5. Is it clear to you? At 5 Canada. So the COPD patient has a respiratory acidosis which is compensated by the kidneys, which will result in a metabolic alkalosis. In the exam, or if somebody asks the diagnosis and asks to interpret the blood gas, you can say that the patient is having a compensated respiratory acidosis. Harini? If you have any questions, you can ask.
Sir, since patient is diagnosed patient with COPD, in resuscitation they have used 15 liters using bag mask. which
Yeah.
means nearly 90%, 95% oxygen.
Yes.
Is that okay to use at
Yeah,
resuscitation?
in any critical ill patient, like if the patient is having a respiratory arrest, our priority would be to oxygenate the patient, because if the patient doesn't have enough, whether it's COPD or anything, if you are worried about oxygen, isn't it? If the patient is having a respiratory arrest, we are at that point. Our priority would be to give as much as oxygen possible. Because if the patient doesn't get enough oxygen because of the respiratory arrest, the patient will end up having a brain ischemia, cerebral ischemia. Okay, so in any patient who is having a respiratory arrest, it would be better to give a high inspired concentration of oxygen initially.
Okay, sir.
Hereby says for say this patient, say the patient is has admitted with the acute exacerbation of COPD, say with a respiratory rate of maybe 16, and you have given 50 liters oxygen, and in that patient, say the respiratory rate gradually drops. Initially it was 16, then 14, 12, then 10. In that case, the hypoxia might be the patient will be depending on a hypoxic drive to stimulate respiration, but because of the high concentration of oxygen, the patient's respiration will be inhibited and the respiratory rate will drop. In that case, you can always use low oxygen concentration. If you reduce the inspired concentration, the patient's respiratory will go up. ඒක වෙනම එකක්. මේක respiratory arrest එකේ priority එක to oxygenate the brain and heart, mainly the brain. නැත්තම් ඉතින් vegetable එකක් කියලා patient නවතින්න ඕනේ. හරිනේ?
Okay, sir. Okay.
ඉතින් තව ප්‍රශ්නයක් තියෙනවා. How can base excess be 12? I think base excess කියන්නේ ඊ කිව්ව දැන් the amount of base which is needed to bring the pH back to normal. The base then මේ patient ගේ metabolic alkalosis එකක් තියෙන්නේ because of the compensation. So he has a high bicarb. That means you need to remove base from the blood to bring the pH back to normal. Then there is no hard and fast relationship between the bicarb level and the base excess. I mean, between the numbers. At your level, if you know that base excess is the amount of base which is needed, which you need to remove or add to the blood in order to bring the blood to normal pH, that means base excess. If you know that bit, it's enough. Okay. වෙන ප්‍රශ්න තියෙනවද මොකුත්? We'll quickly go through the other case. Okay, next question. You're called to the ED to see Mrs. Harris, who has been successfully resuscitated after an out-of-hospital cardiac arrest. Return of spontaneous circulation was achieved after 3 shocks, but she didn't regain consciousness, so she was intubated before transfer. The nurse gives you a SBAR-based handover, following which you carry out a rapid ABCD assessment and find intubated 7.5 diameter ET tube, 22 centimeters at lips, manual ventilation with 15 liters oxygen, 20 breaths per minute, entitled carbon dioxide 2.2. That means 2.2 into 7.5, it's around 15. Good air entry, both lungs, saturation 97. Pulse 126, sinus tachy, blood pressure 94/68. No eye opening, intubated, extended to pain. Nothing gross, exposure, IV in left antecubital fossa. Okay. So what would you expect in this patient's blood gas? What would be the findings? Any volunteers? Milarin පටන් ගමු. කියන්න කවුරු හරි. Sasanka Jayatunga. මම නැත්තම් කියලා ඉවර කරලා දාන්න ටක් ගාලා. එහෙම ගතියක් නැහැ කිසිම.
Sir, there is metabolic acidosis.
ඕකේ දාන්න බලන්න මේ වැලියුස් ටික.
pH is 7.25.
Okay.
And partial pressure of oxygen is around 100 or more than 115, like. And
Okay.
partial pressure of carbon dioxide it's 50.
50.
Yeah.
Why?
No,
දැන් මේ තියෙන entitled 2.2 කියලා. What does that mean?
no,
Entitled
sir, I have no idea.
නෑ කියන්නේ. Entitled CO2 2.2 නේ. What do you mean by entitled CO2 2.2? Do you know the meaning of entitled CO2?
No, sir.
Hello. Sorry, light gear. Sadheen, are you there?
Yes, sir.
Okay, sorry, my light gear toggle. Okay, so entitled, what do you mean by entitled?
In a waveform CAPNO, the partial pressure of oxygen, that is carbon dioxide, that is recorded at the end of in exhalation.
Okay, so that's so Adina, it's a gadget where you fix to the it's a gadget you fix to the endotracheal tube. By that you can measure the concentration of expired concentration of carbon dioxide. So that's known as capnography. So by that you can get a value of the expired concentration of carbon dioxide, which is close to the arterial partial pressure of carbon dioxide. So it shows that it's 2.2, which is 2.2 into 7.5. It's roughly 15 millimeters mercury. It's quite low, isn't it? And so, what sort of carbon dioxide would you expect to have? If it's 15, the arterial one should be roughly around 15. Okay. And regarding the metabolic status, what can you say? What can you say regarding the metabolic status? Cool.
Sir, we can't see the screen now.
You can see. Oh, sorry. Okay, can you see now?
Yes.
Okay. What can you say about the metabolic status in this patient?
There should be metabolic acidosis due to
Okay.
lactic acidosis.
Okay. Did you understand about the capno?
Yes.
Okay, so can you build up arterial blood gas depending on the taking into consideration the details you told? A complete blood gas starting from pH 7.25, then PO2, how much would you expect? Around 100. CO2 is 15. Bicarb, how much would you expect?
18, 20.
Okay, after cardiac arrest, we should expect a value below than that. Okay, maybe 10, 15. Base excess of minus 10, and lactate, how much would you expect?
More than 2.
2 ki ගානක් කියන්නේ 10ක් වුණත් තියෙන්න පුළුවන්. Okay. So did everybody understand how we could work out the blood gas without actually seeing a blood gas? So this patient is a very elderly lady who has had a cardiac arrest. Then there's an important learning point in this blood gas. One thing is you can see that the patient has been ventilated with a respirator of around 20, which has resulted in a carbon dioxide of 2.2. That means around 15 millimeters mercury. That means it's well below the normal value, isn't it? So if somebody after cardiac arrest is being over enthusiastically ventilated, ඒ කියන්නේ නිකන් පණ දාගෙන අමු බෑග් එක දඩබඩ ගාලා මිරිකන් ගියොත් එහෙම the patient will be hyperventilated and will result, then patient will ultimately have a very low CO2. That means it's 15. So that's it. It's not very good for the patient. Okay, somebody has asked entitled PCO2 is equal to PCO2 in blood. Is it right? It's roughly the same value. Like there can be a difference between around 5 millimeters mercury between the entitled and the arterial carbon dioxide. Okay. So I did not understand CAPNO. CAPNO is a gadget where you fix to monitor the expired concentration of carbon dioxide. So if you go to the theater or you go to the ICU, in most of the ICU patients, we fix a capnograph to the patient, to the endotracheal tube. By that, we can get a rough idea about the expired entitled carbon dioxide. And if you look at the monitor of the patient, it will be represented in a graphical form. The කොටු වගේ යනවා. නිකන් දාලා පෙන්නන්න එක. Meeting waveforms. Can you see this?
Yes, sir.
Yeah, මේක තියෙන දැන් මෙහෙම කුඩු යන්නේ මේ ventilator patient ventilator නකට මෙහෙම යනවා. මේක එක waveform එක අනුව you can come to various diagnosis. You don't have to know it. So this is the capno. මෙහෙම යන එක මේක මේ value එක තමයි roughly entitled carbon dioxide value එක. That's usually අපේ මගේ දැන් මට ටියුබ් එකක් දාලා වෙන්ටිලේට් කරොත් සාමාන්‍ය මේ 35 to 45 තියෙන්නේ මේ ලෙවල් එක. හරිනේ? Hope you understood. So in this patient, when you got the entitled carbon dioxide level, it's 2.2 or roughly 15. That means the patient has been over enthusiastically ventilated. You might expect to see one thing is a metabolic acidosis because of the cardiac arrest, and because of this hyperenthusiastic ventilation, you can see respiratory alkalosis. Okay, now let's see what actually the blood gas is. Okay, so she's on 85% oxygen and PaO2 is 25. 25 තිබුණාට මදීනේ 85% තියෙනවා නම් 75% වත් තියෙන්න එපා. So oxygenation is not that good. pH is 7.62. That means there's an alkalosis. So we have to find whether it's metabolic or respiratory. Then we look at the CO2. CO2 is 20, which is well below normal. So because the patient has been hyperventilated with a respiratory rate of 20, there's a respiratory alkalosis. Okay. And bicarb is 20 and base excess is -4. So in this case, bicarb is low and base excess is also slightly low. So there's a metabolic acidosis. Okay. So final answer is the patient has a respiratory alkalosis, which is uncompensated. Or we can say that there's a respiratory acidosis and a slight metabolic acidosis. Okay. Did everybody understand why the patient has a respiratory alkalosis? So that's the importance of ventilating a patient with the correct rate. A post-cardiac arrest patient, we should aim a CO2 of roughly 35 to 40. If the CO2 is too low, what will happen? It will vasoconstrict the cerebral vasculature, isn't it? And it will reduce the blood supply. On the other hand, if you hypoventilate, the CO2 will go up and there will be cerebral vasodilatation, and it will not be good to the brain because vasodilatation will increase the intracranial pressure. So ultimately, if there's the cardiac arrest, our aim should be to prevent secondary brain injury, because if there's a primary brain injury due to poor oxygenation, we can't do anything about it. So in a cardiac arrest patient, post-resuscitation, one of our aim should be to protect the brain. Because of that, we should ventilate the patient with the optimum rate, usually 12 to 14. So how could you say compensated or not? So if you want to say whether it's compensated or not, there are various formulas. So if there's a respiratory alkalosis, if you want to check the compensation, if you put a formula, you can calculate the expected bicarb value for this patient. But at your level, you don't have to know that. At your level, if you say that the patient has a respiratory alkalosis and a slight metabolic acidosis, it's fine. Or maybe partially compensated respiratory acid, partially compensated metabolic alkalosis, because the pH is well above the normal. You can see that since the bicarb is 20, he is trying to compensate. But since an acute stage, there is no time for compensation. How can there be base excess of -4 here with respiratory alkalosis? So the respiratory component and the metabolic component are different. Okay. The patient is having a respiratory acid alkalosis. So that's a different point. And the metabolic component is a different thing. Okay. Respiratory alkalosis එක තිබුණාට patient හදන්නේ kidney එකෙන් bicarb retain කරගෙන bicarb එළියට දාලා. දැන් respiratory alkalosis එකක් තියෙන patient කෙනෙක්ගේ if the patient is trying to retain bicarb then metabolic alkalosis එකක් එනවා. The respiratory alkalosis එකක් තියෙනකොට kidney එකෙන් කරන්න ඕනේ bicarb එළියට දාන එක. urine වලින් pass කරලා යවන එක. එතකොට bicarb අඩු කරගෙන තමයි respiratory alkalosis එකට counteract කරන්නේ. ඒකයි base excess -4 වෙලා තියෙන්නේ. Then may I primary they have this in blood gas. When you interpret a blood gas, you must think about the primary problem. So in this patient, the primary problem is metabolic respiratory alkalosis because CO2 has been washing out. For that, as a secondary mechanism, patient has been trying to compensate.
So,
Oh,
so අපිට පොමට කිව්වනේ මේ බයිකාබනේට් ට්‍රීට්මන්ට් එකෙන් කම්පන්සේට් කරන දවස් කීපයක් යනවා කියලා.
oh,
එතකොට දැන් ඔය පේෂන්ට්ගේ බයිකාබනේට් එකපාරට අඩු වෙලා තියෙන්නේ කොහොමද?
then මේ cardiac arrest එකන්නේ. cardiac arrest එක නිසා acidosis එකක් එනවනේ. ඒක නිසා තමයි මෙයා අඩු වෙලා තියෙන්නේ.
කම්පන්සේෂන් එකක් ඉඳ නෙවෙයිනේ.
නෑ.
සර් thank you.
Right? So make උත්තරේ කියන්න පුළුවන් this patient has uncompensated respiratory alkalosis. So අපිට හරියට formula දෙමම කියන්න පුළුවන්. Patient has a respiratory alkalosis with mild metabolic acidosis කියලා. මේ දෙවෙනි විදිහට කියන්නේ the patient has a respiratory alkalosis plus a mild metabolic acidosis. හරිනේ? අන්තිම එකම වෙන. Okay, last one. So Mr. George is an insulin-dependent diabetic who has been vomiting for 48 hours. Because he was unable to eat, he has taken no insulin. The nurse gives you a S-bar-based handover, following which you carry out a rapid ABCD assessment and find A is clear, B respiratory rate 30, oxygen 6 liters per minute per face mask, saturation 96, air into both lungs, obvious smell of ketones on his breath. Circulation cold and clammy, pulse 120, BP 88/66. There's a saline running. GCS is 13 and slightly distended abdomen, 10-node examination, no bowel sounds. You take a blood gas. Okay, what would you expect to see in this patient in the blood gas? Hold the key. Any volunteer? Because this is the last one. Anybody can shout out. iPhone game බලන්න. Huawei Y7. අනේ කවුරු කියන්නකෝ.
So there should be high anion gap metabolic acidosis with respiratory alkalosis due to hyperventilation.
Okay. Iron gap එක කාටවත් තේරෙයිද දන්නේ නැහැ නිකන් සරලව කියන්නකෝ. Metabolic acidosis, there should be a metabolic acidosis which can be compensated, isn't it? හරිද? Cool.
Yes, sir.
PM values ටිකක් දාන්න බලන්න. Don't tell about the anion gap because everybody won't be able to understand it. Just tell the metabolic acidosis with respiratory alkalosis කියන්න he will be trying to compensate, isn't it? So you can expect to have a metabolic acidosis which is compensated or which is partially compensated. Ne? Can you put some values starting from pH? Cool.
pH 7.3 3
Okay.
to 5.
Okay.
Partial pressure of oxygen, it's 100.
Okay.
And partial pressure of carbon dioxide is around 35, 30,
අඩු ගමුනේ 25ක් විතර දාමු. Okay.
25.
Okay.
And bicarb, it's around 10, 15.
Okay.
And base X is minus 15, 10.
Okay, right. So first you told that the patient can have a metabolic acidosis with a respiratory alkalosis. We can the both answers will be correct. So as you can see, this is a classical history of diabetic ketoacidosis, isn't it? The patient has been unwell for 48 hours without taking insulin. So because of the deficiency of insulin, the patient has got features of diabetic ketoacidosis. So because of the accumulation of ketones in the body, because it will create a metabolic acidosis. So the patient will try to hyperventilate and compensate it from the respiratory system. Okay. So one answer is, if the patient is adequately compensating, you will get a blood gas picture which shows a compensated respiratory acidosis. Sorry, compensated metabolic acidosis. Okay. One picture is the patient will get a compensated metabolic acidosis because the lungs are doing their job well. The lungs will be clearing CO2. But if the patient is rapidly hyperventilating, the patient will be clearing more CO2. So at that point, the patient can have a metabolic acidosis plus respiratory alkalosis. ඒක තේරුණාද? සමහරවිට තියෙන්න පුළුවන් metabolic acidosis එකත් එක්ක CO2 හොඳට මේ wash out වෙලා patient can have adequate compensation. එතකොට තියෙන්න පුළුවන් compensated metabolic acidosis එකක්. Otherwise, if the patient is overventilating, the patient can have metabolic acidosis plus a respiratory alkalosis. ඒක තේරුණාද? Did you understand that?
Yes, sir.
Okay, so this is the blood gas. PO2 is 17. So he's on 30%. 30 කියන්නේ එතකොට 20 ට තියෙන්න ඕනේ. 20 into 7.5 150 නේ. So oxygenation is not that very bad. It's okay. pH is 7.06. That means the patient is acidotic. Then we have to see whether it's metabolic or respiratory. CO2 is 23. So it means that it's not respiratory. It means that the respiratory system is trying to compensate because it's low. Bicarb is 6.3, it's very low, and base X is minus 21. So both are favoring towards the metabolic acidosis with compensation. So there is now in this patient, there is a value which shows that there is adequate compensation. You can put into formulas and know the value, get the value for this compensation to see whether there is adequate compensation. By that, you can say whether the patient is having adequate compensation or respiratory alkalosis. But in this patient, if you see this blood gas, since the pH is 7.06, that means there isn't adequate compensation. You can say since the CO2 is 23 because it's towards the low side, it's partially compensated. So the final answer in this patient will be the patient is having a metabolic acidosis which is partially compensated. Any questions regarding that? මේක ප්‍රශ්නකුත් තියෙනවද? So you can ask any question regarding this, regarding three blood gases. So I read the feedback. So most of the people, some people have told that, some students have told that it's difficult to concentrate after 1 hour. The problem is, okay, sir, could you please explain case 3 again? Not understood. Okay. So if we limit to 1 hour, I can tell G1 whether you want to limit the classes to 1 hour or not. Then we have to continue it in separate classes. It's okay with me, but if you all okay, if you all agree, I can do like that, because some people have told that it's difficult to concentrate after 1 hour. Then we can stop at 1 hour. Then we can do what we can continue it like on another day. So you discuss it with your among yourselves and let me know the best option. Case 3 what is the problem? 1 hour classes are better. Okay. Could you please explain case 3 again? Not understood. What I'll tell. Okay. So we'll meet next Saturday or Sunday. Wednesday next Saturday or Sunday Okay, so the case 3 is there's a 71-year-old male patient admitted with an acute exacerbation of COPD, had a respiratory arrest, and you have